Okay, we're going to call the meeting to order and rise for the Pledge of Allegiance. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome, everyone. So we'll start with the roll call.
Okay. Director Wallace?
Present.
Director Nicholson?
Present.
Director Danielson?
Present.
Director Stewart?
Present.
And Dr. Epen is away.
Okay, thank you. Okay, Nancy, we're going to begin the education session.
Yes, I would like to begin by introducing to you our speaker. He's well known to most of us here at the hospital. He was requested by the Cleveland Clinic Department of Neurosurgery to give a very prestigious lecture to the graduating class. It's called the Gardner Lecture. He was asked by Dr. Edward Benzel, chairman of the Department of Neurosurgery at the Cleveland Clinic. The Gardner Lecture is named for the second chairman of the Department of Neurosurgery at the Cleveland Clinic, James Gardner, MD, who was in that position for 35 years and responsible for many of the modern advances in neurosurgery that we enjoy today. Originally, prominent chairmen from neurosurgery programs all over the country were invited each year to speak to these graduating residents. And starting about 10 years ago, distinguished alumni of their neurosurgery training program at Cleveland Clinic began to be invited to give this annual lecture. This year, the Gardner Lecture was given by our very own Moses Tagioff. He's been a member of our medical staff since July of 1973. His specialty, as you might imagine, is neurosurgery. He's currently the medical director of perioperative and strategic surgical services at Washington Hospital. He has also been our chief of staff at Washington Hospital, and he received his medical degree from the University of Bombay in 1966, completed his surgery residence at Albert Einstein Medical Center in Philadelphia, Pennsylvania, and his neurosurgery residency at the Cleveland Clinic in Cleveland, Ohio. Dr. Tagioff lives in Pleasanton with his wife, Nafisa. He has 2 adult children and is the proud grandfather of 3. With that, I'd like Moses to come forward. He's going to be giving to us the same speech he gave at the Cleveland Clinic.
Thank you very much, Nancy, members of the board, fellow physicians and friends. When I was in practice, one of my patients asked a nurse on 6 West, "How long has he been a neurosurgeon?" And she said, "What do you mean how long? He was born a neurosurgeon." Having said that, I didn't say this at the clinic, but today is exactly 43 years. It was Friday the 13th of July, 1973, that I did my first surgery. And all my life I've been here at Washington Hospital, and I'm very proud to say that. My talk is about footprints, and I address the graduating class at the Cleveland Clinic. Basically, I've broken my talk into 3 parts. I wanted the residents there to know who Gardner was. So we're going to talk a little bit about Gardner. I might bore some of you, but Gardner was an absolutely amazing man, and you guys have to hear a little bit about him. I also am going to talk a little bit about myself as to why I was there in their presence. And finally, I'm going to talk about them, the graduating class, and the do's and don'ts of going into the world. I called my talk Footprints because I wanted to tell them about their footprints. This is what they gave me as I left. It's a glass award, and the globe on top revolves. And I agree with everything they say on it except the last line. Having said that, I wanted to let you all know that three of the neurosurgeons at Washington Hospital came from the Cleveland Clinic. The first neurosurgeon was Dr. Stanton Schiffer, who was my chief resident. The second was me. And the third neurosurgeon is still with us today, Dr. Desmond Erasmus. Because this lecture is designated the Gardner Lecture, I thought it would be appropriate to tell you a few words about this amazing man. Contrary to many assumptions, Gardner was not the first neurosurgeon at the Cleveland Clinic. The first neurosurgeon there was Dr. Charles Locke. And it's very interesting to learn how Gardner came to be at the Cleveland Clinic. Dr. Charles Locke was born, I'm not sure, but I think he was born in San Francisco. He was recruited to the Cleveland Clinic as the first neurosurgeon by a man called Howard Nafziger. Of all places, that's the man who's circled. Howard Nafziger was a professor of neurosurgery right here in San Francisco at UCSF. In 1929, a devastating fire erupted at the Cleveland Clinic, and it was in the X-ray department. There were thousands of nitrocellulose X-ray films that burst into flames. He was on duty. That's Dr. Charles Locke. He managed to escape. He actually did not get burnt at the fire. He climbed up, and there was a skylight. He got out of it. But he had inhaled so much of the fumes that 4 hours later he became cyanotic, could not breathe, and he died of pulmonary edema. When Dr. Nafziger heard about this, he decided he must send another replacement. So this is where Dr. Gardner steps in. Gardner replaced the existing chief of neurosurgery, Dr. Charles Locke. Now, Gardner was born in McKeesport, Pennsylvania. That's your town. And he obtained his medical degree in 1924. He went to the University of Pennsylvania. He spent some time with Dr. Charles Frazier, who is a very, very well-known neurologist from the East Coast. Dr. Frazier was not a neurosurgeon, but he did dabble in some neurosurgery. And then he worked with Dr. Spiller, another neurologist, and when they heard about the tragic news of the death of Dr. Locke, they told Gardner, go to the Cleveland Clinic. When Gardner came to the Cleveland Clinic, he didn't realize he was going to be there for 25 years. During his 25-year career, that's Gardner, by the way, as a young man, he invented many, 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 many things. He had 200 scientific papers. He described for the first time the sitting position in neurosurgery. Nobody had ever done that before. He invented what is called the G suit. You can see him putting on the G suit. G is for Gardner. This is what keeps the blood in the head when you sit a patient up and does not allow you to suck in air from the brain and create what is called an air embolus. Many deaths occurred that way before the G suit was invented. In order to sit up in a sitting position, he had to create a chair. This is called the Gardner chair. You see the head points that hold the patient's head. That's his invention. He described tantalum cranioplasties while he was in the Navy. Tantalum is a metal, and he repaired all the skull defects with metal. Anyway, his career spanned over 35 years. He had great interest in what is called trigeminal neuralgia. He described the Chiari malformation. And the list goes on, and I'm not going to bore you. He trained a total of 28 residents and partially trained 14. Besides his active career as a neurosurgeon, he also had a great personal life. He was the father of 3 children. He served as a private in the U.S. Army, and then in World War II, he became a lieutenant commander in the U.S. Navy. He found enough time to enjoy hunting, fishing, ice skating, tennis, and participated incessantly in barber shop quartets, much to our we were suffering when he sang, but we had to listen to him because he was the boss. He retired at the age of 64 into private practice in Cleveland, Ohio, and he was there till 1987 when he passed away. By the way, if you haven't noticed it, that's Dr. Donald Doan, the chair of neurosurgery, awarding Dr. Gardner the Congress of Neurological Surgery Award. Now I want to tell you a little bit about how to live your life, because I believe in change. Be the change you want to see in the world. That was Mohandas Karamchand Gandhi's most famous saying. And there he is, Dr. Doan. This was when he came here to Washington Hospital to talk to us about, at one of our sessions, he spoke about mentoring, and at the time that he spoke, people at the Cleveland Clinic liked what he said, so they plagiarized his entire speech, many of them, and they kept giving it, pretending to be their talk. Here's Albert Einstein, who also talks about change. Be the one who can change what is possible. So let me tell you why I'm here today for you. I want to talk to you about your life moving forward. Think about these words for a moment. Be the change who can change what is possible. I always wanted to become a heart surgeon. I wanted to do the FRCS diploma. As Dr. Achanta, you know that every young man, at least during my day, wanted to become an FRCS. The Mecca was always England. So I went to the British Embassy when I just finished my training, and I was entering my internship, and I told them I wanted to go and become a heart surgeon in England and get an FRCS degree. They told me I couldn't do it for 3 more years. And I was broke. I had no money. I was married. My wife was just about to deliver our first child, Michelle. So I told the people at the British Embassy that it's going to be their loss. If they don't give me a visa now, I'm going and I'm never coming back here. I didn't know what I was going to do, but I said that and I walked out. That very night, I went to a party, and G.K. Chesterton once said, the amazing thing about miracles is that they do happen. I went to this party. It was in Malabar Hill, as it's called, and I sat in the corner. My wife was with me by my side. I was upset, severely disappointed, angry, and a total stranger whom I'd never met before came and sat by my side. His name, Noel Guiozé. I remember it like it was yesterday. I hear you're a doctor, he told me. I said, yes. I'm a doctor too. I said, yes. I didn't want to talk to him. And he said, I'm a pediatrician. I've come here to inoculate the children of India. So I said, okay. And then he said, I'm with the Peace Corps. I've come here from the Cleveland Clinic. So then I told him my sad story that the UK embassy had told me, no, go wait 3 more years. He burst out laughing. He said, why are you going to England? That's passé. Nobody goes to England anymore. Go to America. Heart surgery? Cleveland Clinic? So I said, where's the Cleveland Clinic? He said, in Cleveland. Where's Cleveland? I said, and he said, that's New York. This is literally the way he said it. That's Los Angeles, and that's Cleveland. Okay. Somewhere between New York and Los Angeles. Write this down. Piers H. Mullally, Director of Medical Education, St. Vincent Charity Hospital. That's the back door to the Cleveland Clinic. I said, but if I apply to the Cleveland Clinic, they'll think I'm charming snakes and riding the backs of tigers. He said, no, 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 no. Ride to Pierce Malali. He's the director of education at St. Vincent Charity Hospital. As Ed will tell you, it's downtown in Cleveland, and all the residents from St. Vincent Charity, from the Cleveland Clinic, go to St. Vincent Charity Hospital to do their surgery on indigent patients. So I said, okay. He says, that's the back door. They'll see how well you work and you'll get into the clinic. Okay. So I wrote down his name and address. And then I said, what do they pay interns? He said, $300 a month. My wife was sitting next to me. Big smile broke out on her face. $300 a month was an enormous sum. I was working in a hospital as an admitting clerk for 40 rupees a month, which is a little over $50. So I wrote to Pierce Malali, and he sent me a DSP 66 form, which is a visa, in exactly 3 weeks, almost exactly to the day. So we went to Cleveland. I had $8 in my pocket. My wife was with me. My newborn daughter was 3 months old. And we arrived at St. Vincent Charity Hospital in Cleveland, Ohio. Now, the man that's circled there was a very, very prominent neurosurgeon in private practice in Cleveland, Ohio. His name was Ed Bishop. So the first night that we had all gathered at St. Vincent Charity Hospital, Dr. Malali made 28 residents sit all around in a room. And all he did was, I want each of you to say one sentence in English. Not a single intern could speak in English. The gist of the conversation was, hello, how are you? Thank you, goodbye. When it came to my turn, I told him my name, my age, and why I was there. He said, good. Tomorrow you're going to help Ed Bishop remove a brain tumor. I was absolutely mortified. The resident from the Cleveland Clinic did not want to come to St. Vincent Charity Hospital. That was a miracle. So they put me there instead. But I cannot go to the OR. I've never seen a brain tumor and I've never done brain surgery in my life. He says, no worry, you go. You owe me. Remember? You wrote to me 3 months ago. Now you owe me. All right. I was awake all night. My wife by my side. I was trembling. Got up like at 4:30 that morning and we went to St. Vincent Charity Hospital to remove a brain tumor. Bishop walks into the operating room. It was at 7 in the morning. I looked at him. He was tall, well-dressed, and I don't know if you can see it. He had a butch haircut, very much not in style at the time. He had come from the Korean War. And I addressed him. I said, Your Honor. He said, don't call me Your Honor. I'm Dr. Bishop. We're going to take out a brain tumor. So what are you going to do with your life? I said, I want to become a heart surgeon. He says, what? Are there any cardiac surgeons here? Any old fool can do heart surgery. You got to do brain surgery. So I said, well, let's see. So we went in and we did the craniotomy. It was a very malignant brain cancer, the same thing that our dear Taylor McAdam Bell had. While we were in the operating room, he told me that the brain was the most beautiful organ you can ever lay your eyes on. And if you look carefully, you'll see it pulsating. He was very dramatic. He said, look, lad, look. Anyway, I stood, I looked, and then I said, well, maybe I'll consider being a brain surgeon. Surgery went well. I asked him, how do I become a brain surgeon? He says, why, there's no other place but the Cleveland Clinic. His name is Dr. Donald Doan. He's my very dear friend. Call him. Tell him I sent you. Okay. That night, I went home and I did one of my first of many guess whats. I told my wife, Nafisa, guess what? I'm going to become a brain surgeon. So that's what made me do that. Now, I called Dr. Doan's office while I was an intern, and I called him again and again and again and again. almost 3 months. At the time, they never had assistants, they had secretaries. And his secretary's name was Mary Axe. We were on a first name basis. Mary Axe, I want to speak to Don Doan. No, you can't, he's busy. You can't. No, you can't. And then when we got on first name basis and I started calling her Mary and she started calling me Moses, finally she said, okay, I'll give you 1 minute. I don't care whether you're talking or he's talking. In 1 minute, 60 seconds, we're going to hang up. Okay, thank you, Mary. So he comes on the phone and he says, who are you? Are you a patient? I said, no, no, no. I'm a doctor. I'm at St. Vincent Charity Hospital down the road. And I want to come and study neurosurgery. Your friend, Dr. Bishop, told me to call you. Okay. He says, have you applied? I said, no. Why have you not applied? Because I don't want you to refuse me before you see me. He liked that. Okay, he said, tomorrow, come at 5 to the doctor's changing room, in the locker room. I said, all right, I'll be there at 5 in the evening. No, 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 5 a.m. Okay, and don't be late. That interview, that's Dr. Doan, by the way, in the same photograph. And we'll get back to this photograph later. That's me. That's Dr. Gardner. And if you look carefully, I don't have a circle, but 2 physicians to my left is a very familiar face. Desmond Erasmus. I managed to get him here too, by the way. Anyway, so that brings me to my stint. Now I'm at Washington Hospital in Fremont, California. How did I get to Washington Hospital? In my 3rd year of training, Dr. Doan said, go anywhere in the world you want to go. So I decided to go to London, England, and show them how good I had become. So I went to the Mecca of neurosurgery in London. It's called Queen Square. And I worked with Professor Valentine Loeb, the biggest name ever outside America. Valentine Loeb was an Australian knighted by the Queen. And his father, if any of you saw the movie The Queen's Speech, his father taught King George VI how to stop stammering. Anyway, while I was working at Queen Square for about 3 or 4 weeks, I got this page overhead. Dr. Tagioff, please pick up your page. And there was Dr. Stanton Schiffer on the page. By the way, that made me famous over there because here's a resident from America who's getting calls from America. Hi Stan, what are you doing in London? He says, I'm not in London, I'm in Fremont, California. I said, where's Fremont? We went through the same dialogue. And he told me, you know, the BART train, it occasionally stops there. That year, the BART line had come to Fremont and never stopped. It kept going. So I said, so what do you want? He says, I want to come to London and see you and ask you to join me in private practice. Okay. He says, you know the Churchill Hotel? I'll be in the lobby next Monday. I'm going to bring Joan and we're going to talk about you coming to Washington Hospital in Fremont, California. He came with his wife Joan, and at those days we never had smartphones, we had Viewmasters. He brought pictures of Washington Hospital, the Bay Bridge, the BART train, the gladiolus in the back of the hospital growing. And none of that really excited me until he put up this picture. A huge lemon tree. This is not his lemon tree, but it was exactly like this. And sitting right in that lemon tree was his son Eric, whom I knew. And Eric's face was as big as the lemons. And I said, what's that? He said, that's my lemon tree. Where is that? In my backyard. I said, if I come to Fremont, can I have a lemon tree like that? He said, sure. He said, the weather and the soil is so good, you put a seed and jump out of the way. Those were his words. Because it grows so fast. I'll pay you lots of money and next year you'll become a full partner. Thank you. He smiled. I put out my hand. I told him, go back, get your attorneys to draw up a contract. So that's how I wound up in Fremont, the famous lemon tree. Now, let's talk about you as residents. We got to talk a bit about life balance. Work hard. Do not neglect your family at all cost. You need to establish life balance in order to be successful in what you do. Your family will be your foremost contributor to what you do and to your success in life. I'm not going to mention names, but I had one of our neurosurgeons in mind. As a neurosurgeon, there will be constant pressures from you, not only from your patients, but as your peers as well. Do not neglect your family in spite of all these pressures. It will not occur automatically. You have to make time for it. And learn to love what you do. Then I told them that Confucius once stated, choose a job you love and you'll never have to work a day in your life. I believe that axiom is very, very true. Now I want to talk to you about the truth. As I started preparing this lecture, I got to talking with one of my colleagues right here and asked him if they were very, very, very sick, what would they expect from their physician? And his answer, he said, was, I'd expect the truth. His wife was very, very sick, and the internist who was treating his wife did not divulge the real truth to him. That broke his heart. He did not forgive this internist, even till this day. Well, if I have to give you all just 3 words of advice, I would say, tell the truth. And if I had to add 3 more words, I will say to you, all the time. Don't ever divulge from that. Now let's talk a little bit about empathy. Empathy is not the same as compassion. Compassion is something we feel when we see someone who is in need. It's a result, and as a result we are motivated to help that person. That's compassion. Empathy is not to be confused with sympathy, which is also an emotion, a feeling for someone who is in need. In order to experience empathy, you need to listen to your patients.
Listen to me. Like I do this all the time, and if I go out at the house or to the door, Matthew has his toys, and then Matthew has all his toys.
Okay, but I have to yell at you guys.
Listen.
When I was in practice in Fremont, every Friday at 4 o'clock, I shut my office down. We had 9 employees. I was the only physician in the practice. And basically we'd sit around and we'll talk about pet beefs, what went wrong that week, what we should do to correct it. But I would start that session every single time with a reminder that when your patient comes into this office, it's the worst time in their lives. Remember that and listen to them. Okay? My first lesson in empathy, I remember a 20-year-old son of a podiatrist in our community had come to see me with his mother. He was exercising and he was lifting weights above his head and his legs gave way. He fell to the floor. When he came to my clinic, I examined him. He had weakness of both his legs. I did some studies and I found that his spinal cord in the thoracic area was widened. Took him to surgery. I opened his spinal cord, which is not commonly done in private practice, and I used the laser and I cut his spinal cord open. I biopsied it. It turned out to be a very unusual diagnosis for the spinal cord. Glioblastoma multiforme of the spinal cord. Very unusual. So when his wound was healed, I had her come with her son to my office. I sat with her and I told her what was going on, he would probably not see the end of the year. When I told her this, she burst into tears, sobbed, and shouted at me, "What have you done to my son?" I didn't say a word. I held her hand. I listened to what she said. She sobbed. And that boy died a few months later. That was my first lesson in empathy. I'll never forget it. Now, something I hope that none of you will ever face in your life, and that's malpractice. By the end of my career, 50% of everything I'd learned at the Cleveland Clinic was not what I practiced, because things had changed. It's of the utmost importance to keep up with the literature because it's changing all the time. Join the AANS, join the CNS, keep current with the medical literature. When you are well informed, your patients will be well informed and they'll know what to expect from you. When I went to England, Dr. Doan told me, "Moses, if you do not learn how to do it in England, learn how not to do it, but learn." I was in my first week in private practice and I was in Livermore. I came back and the next day Dr. Schiffer made rounds in Livermore Valley Memorial Hospital. He came back and told me, "You're a very famous man now in Livermore." And I said, "Why?" He says, "You're on the front page of the newspapers." What happened? It seems that an orthopedic surgeon who was not experienced in surgery of the spine had actually done a misdiagnosis. He had diagnosed a lumbar spinal canal stenosis from multiple disc protrusions. The man was literally just married. His wife was there with him. He woke up paraplegic. He could not move his legs, could not control his bladder, his bowels, and he could not stand or walk. They consulted me. I went to Valley Care the next day. I saw the patient. I saw his myelogram. That time we had no scans. And I said, "Oh my God, this is not multiple disc protrusions. This man has lumbar canal stenosis." So I went to the radiologist and they hadn't heard of that entity. So I had to educate them. Then I went to the floor and I had to educate the patient and his wife. I said, "Your best chance to get well would be to have you go back into surgery and let me open your spinal canal. Your nerves are being choked." With great reluctance they agreed. I took him to surgery, opened his back, and I noticed that his dura was torn open, the nerves were bulging out, there was spinal fluid everywhere. So I repaired everything and put things together, opened the bones, the compression was relieved. He got up. Next day he could stand, the next day he could walk, and eventually went home. However, I learned from him much later in a very hard way that he had never gained his bladder or bowel control or his ability to have erections. So this is what Schiffer tells me: "You are now a famous neurosurgeon in Livermore. I just read the morning paper which reads, 'Neurosurgeon renders his patient paraplegic with botched spine surgery.' The plaintiff wanted $10 million from me. I was afforded a malpractice defense attorney and I was very, very, very upset. So I went to Oakland where my defense attorney was and he said, "No problem, we'll make it go away, we'll just give them $350,000 and it'll be all fine." But I didn't do anything to him. I saved his life. He said, "No, that's the way it's done. We settle cases." I came home, spoke to Nafisa. I said, "Let's go back to Bombay. We don't want this nonsense." And then I got the sudden sad news that the attorney had developed cancer of the throat and couldn't talk anymore. So his partner took on the case. And when I went to see him, he told me, "We are not settling, we're going to fight this." And then he mumbled something to me. He said these words, "Illegitimi non carborundum." Didn't make any sense to me. After my deposition was taken, they dropped me from the case. All they needed from me was to state that the orthopedic surgeon did not know what he was doing, and I helped him. By the way, the literal translation of those words are, "Do not let the bastards grind you down." I've lived with that knowledge all my life. You have to keep on with your work. Now, a couple of words about mentoring. Remember to always share what you have learned with your colleagues and your junior fellows around you. You are now more experienced and knowledgeable by far by virtue of your excellent training here at the clinic. Not only do you have a vast experience and knowledge, but you bring with you something much more rare. That word is wisdom. You have to share this wisdom that you have acquired with anyone who wishes to learn and be a role model. Be confident in whatever you do, and most of all, be reliable. Know your limitations, and above all, do no harm. A very wise man, Swami Vivekananda, who was really quoting the Bhagavad Gita, once said, "Ask nothing, want nothing in return. Give what you have to give. It'll come back to you multiplied 1,000-fold. But the attention must not be on that. You have the power to give, and there it ends." In conclusion, I need to talk to you about a 19th century American poet, Henry Wadsworth Longfellow, who stated in his poem, A Psalm of Life, "Lives of great men all remind us we can make our lives sublime, and departing, leave behind us footprints in the sands of time." So for each of you in the graduating class, I want to tell you this. I've made copies of the Hippocratic Oath. I'm going to give it to you. Take these copies of the oath, frame them, put them up on your walls in the office, and once in a while, read them, because it'll keep you on the path. Thank you. Have a great life. And remember, never, ever retire. Thank you all.
That was very good. Thank you. Thank you. Oh. Okay, we are going to move to the minutes, consideration of the minutes of these various meetings. Can I have a motion for that?
So moved.
Second.
Okay, Colleen?
Director Wallace,
Aye.
Director Nielsen,
Aye.
Director Stewart,
Aye.
Director Danielson.
Aye.
Okay, thank you. We'll now have communications. Are there any oral communications tonight? Okay, we're going to move on to the written communications from Dr. Achanta. Thank you.
Thank you, Dr. Wallace. I have a fairly lengthy credentials report to give. I apologize. Marcos Alvarez, MD, Interventional Radiology. Neeti Doshi, MD, Pediatric Hospitalist. Lance Hine, Physician Assistant in Cardiac Surgery. George Liu, MD in Neuroventricular Radiology. Stephanie McGuire, Physician Assistant in Cardiothoracic Surgery. Seema Sehgal, MD, Psychiatry. Bethany Woomer, MD, Pediatric Hospitalist. And finally, Ming Zhao Stein, MD in Anesthesiology. These are our new appointees. Two of them have sought temporary privileges. Stephanie McGuire, Physician Assistant, Cardiothoracic Surgery, and Lance Hine, Physician Assistant, Cardiothoracic Surgery. For the reappointments, we have Fareed Ramzi Ashfar, Infectious Diseases. Robert Becker, MD, Anesthesiology. David Bell, MD, Orthopedics. Barbara Boyer, DO, Family Medicine. Eldon Eichbaum, MD, Neurosurgery. Leif Erickson, MD, Emergency Medicine. Marietta Fry, MD, Pediatrics. Gabriel Herskew, MD, Vascular Surgery. Helen Ho, MD, Internal Medicine. Ritesh Jha, MD, Gastroenterology. Lee Ko Kwang, MD, Infectious Diseases. Sandeep Kunwar, MD, Neurosurgery. Jay Lee, MD, Internal Medicine, Victoria Leaphart, MD, Gynecology, Jeffrey Lenchner, MD, Emergency Medicine, Robert McCabe, MD, Infectious Diseases, James McGuire, MD, Neonatology, Donna McMillan, MD, Pediatrics, Sylvia Molitores, MD, Infectious Diseases, Elisa Monticelli, MD, Pediatrics, Hemant Patel, MD, Internal Medicine, Jack Rose, MD, Neurology, Yao Sun, MD, Pediatrics, Elizabeth Trainer, MD, Pathology, Dennis Unson, MD, Pediatrics, Aiko Walter, MD, Internal Medicine Hospitalist, Sean Wang, MD, Otolaryngology, and Romy Yun, MD, Anesthesiology. Total of 29 reappointments this month. For the transfer of staff category, Dr. Helen Ho, MD, Internal Medicine, is moving from active to ambulatory, and Donna McMillan, MD, Pediatrics, is also moving from active to ambulatory. Completion of proctorship, Roger Goldberg, MD, Ophthalmology, Munir Jan Mohammed, MD, Cardiology, Kuljit Multani, MD, Hospice and Palliative Medicine, Mona Tafti, MD, Teleradiology, and Noga Ravid, MD, Pediatric Hospitalists, or have completed their proctorship. New privilege requests, we have Megan Swan, Hospice and Palliative Medicine, requesting Hospice and Palliative Medicine privileges. Christopher Nguyen, Critical Care Medicine, requesting critical care privileges. Deletion of privileges. There is a typo in the first two candidates. Fareed Ashfar, MD, Infectious Disease is relinquishing the internal medicine procedures, not privileges, but procedures, as is Dr. Helen Ho. Internal Medicine is relinquishing the internal medicine procedures part of the privileges. Jay Lee, MD, Internal Medicine, is also doing the same. Jeffrey Lenchner, Emergency Medicine, is dropping assisted surgery. Robert McCabe, Infectious Disease, is giving up assisted surgery, ICU, CCU privileges, and internal medicine procedures. Donna McMillan, Pediatrics, is relinquishing the procedures in pediatrics. Megan Swan, Hospice and Palliative Medicine, is relinquishing privileges in emergency medicine. And Aiko Walter, Internal Medicine, is also giving up internal medicine procedures. For the resignations, we have Keith Bursch, PA, in orthopedic surgery. He's no longer employed with his current group. Ninesh Gandhi, cardiology, has moved out of the area. Sylvia Hong, MD, in family practice, is no longer practicing at the hospital. John Lin, anesthesiology, has joined another group. Ricardo Navarro, anesthesiology, has not completed his application and is deemed resigned. Dosh Sharpal, infectious diseases, no longer practicing in California. And Rajni Sethi, radiation oncology, has joined John Muir Cancer Institute.
Okay, that's a lot of work.
Yeah, I know.
Thank you. May I have a motion for approval of the credentialing action items?
Mr. President, I move for approval of the credentialing action items as presented by Dr. Achanta.
Thank you.
Second.
Thank you. Colleen?
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Danielson.
Aye.
Okay, thank you. We are now going to move to the Service League report, Debbie.
Hi, good evening all. Service League, things are a little bit quieter overall. I'm quite busy, but it's pretty quiet right now. But we did have a few things that we were busy in this last month. One of them was our ice cream social. We did an ice cream social. What we've done is to honor our volunteers for their hours of service. And we have it here and down in one of the auditoriums, and it turned out to be a great success. We had the chocolate and the vanilla and the strawberry ice cream with the toppings, and just we've opened it up, like I've mentioned in past meetings, as a social thing. And we had quite a few volunteers be able to attend, and that was really rewarding. And we got to recognize one of our volunteers who has given many hours of volunteer work, and that was Luis Fernandez, honoring him with 16,500 hours. That's a lot of volunteer hours, and we can't thank him enough. But we can't thank all our volunteers. I don't care if it's 1 hour or 16.5. It all matters, and it all makes a difference. So we will have our next one on December the 6th, and now the social committee gets to figure out what they're going to do for that one. But it should be a good time, and we hope everybody will come. Another thing that we have done is we started a new pilot program in the infusion center of staffing. We just started it actually this week. The board approved it, and Sydney staffed it on Monday. I staffed today, this morning, and on Friday, Diane will do it. And this is a 2-month program to see if it works for them, if they're happy with us. But from my account today and listening to Sydney on Monday, it was quite a success. And very interesting. The staff was delightful, and being with the patients is nice to be able to talk to them, give them a warm blanket, things of that nature, just to make the experience maybe a little less stressful for them. So that's something new that we're doing as well. 4th of July parade. Myself, Pat was there, Cherie was there, our first VP, Angus was there, Shannon was there, and Marlene Moybell was there, and we had a great time. And our float was beautiful. It was beautiful. Big old flag, wasn't it, Pat? It was gorgeous. And everybody had a good time. I know I had a good time. And the audience was wonderful. They all seemed excited to be there, and the weather couldn't have been better. So that was a good time. I'm looking forward to it next year. And the float was just gorgeous. I want to thank the hospital for doing that and putting that float together, because it was definitely worthwhile. We had our orientation this last month. We are really trying to move up and get as many volunteers on as quickly as possible. And this time we had 27 new volunteers consisting of 1 adult, heavy on the students, 10 college and 16 high school students for the summer especially. And it always helps to have those because they do bring that youth into the program, and we really enjoy that. Staffing, how many volunteers staffed? Well, adults in hours-wise gave 1,508 hours of volunteer. Our college students gave us 384 hours of volunteering. Our juniors, high school students, gave us 380 hours. And our spiritual care, 288. And our trainees, those are volunteers that are learning to staff in various areas. They gave us 184 hours, giving us a total of 2,744 hours of volunteer services last month. And I want to thank every volunteer, because we can't do it without you, and you do make a difference. And that pretty much covers it for right now.
Okay, thank you, Debbie. Any
You're
questions? Well, thank you very much.
My pleasure.
Back to you, Dr. Achanta.
Well, there is no change in the number of physicians we have on staff. I'm happy to report that we stay at 573. We have 360 active staff members. We have 3 in administrative positions, 19 allied health professionals, 71 ambulatory physicians, 3 in consulting positions, 27 in courtesy position. We have 4 locum tenens physicians. We have 2 allied health professionals who we just sent through credentials, who are in the provisional category, and we have 82 provisional active staff MDs, for a grand total of 573. So
Wow.
we are
Pretty
robust
big.
and
Robust.
continue to grow.
Yeah.
Usually July is the last month of the recruiting period, so it's a little slow, and then we pick up big time in August, because most of the training programs finish in July. And so our ranks swell afterwards in this next 6 months. So we are going to be busy with that.
Well, thank you, Dr. Achanta.
It's a pleasure.
Yeah. Hospital calendar, please.
Yeah, go ahead with the film, please.
Past health promotions and outreach events. On Saturday, June 11th, Washington Hospital participated in the Fremont Police Safety Fair. The event featured safety booths, activities for children, crime prevention seminars, child safety seat inspections, and more. Washington Hospital provided blood pressure screenings along with health and nutrition information. 58 people received blood pressure screenings and over 400 people attended the event. On Saturday, June 25th, Dr. Ash Jain, cardiologist, and Dr. John Thomas Mahegan, vascular surgeon, screened community members for peripheral vascular disease. This free screening included a Doppler study of circulation in the legs and an interpretation of results. This event was co-sponsored by Fremont Bank Foundation. A total of 98 people were screened. Of the 98, 7 were found to have possible arterial disease and 18 were found to have other vascular issues requiring follow-up. On Monday, June 27th, as part of the Speakers Bureau, Dr. Victoria Leapart, gynecologist, presented Stress Management to the Parkinson's Support Group at the Fremont Senior Center. 15 people attended. On Tuesday, June 28th, as a follow-up from the peripheral vascular screening, Dr. John Thomas Mahegan, vascular surgeon, and Dr. Gabriel Herskew, vascular and endovascular surgeon, presented Pain When You Walk, It Might Be PVD. 37 people attended. On Monday, July 4th, representatives from Washington Township Healthcare District Board of Directors, the Washington Hospital Service League, and the Washington Hospital Employee Association participated in the annual City of Fremont 4th of July Parade. The Washington Hospital Float took second place in the category of Commercial and Professional Float. The parade, which took place in the downtown district of Fremont, featured specialty floats, marching bands, and local celebrity guests. Thousands turned out to watch this event. Washington Hospital was a sponsor of the parade. The 2016 Central Park Summer Concert Series kicked off on Thursday, July 7th. Washington Hospital is the co-presenting sponsor. All concerts are held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. and are free and open to the public. Washington Hospital will be providing health information and health screenings during this 6-week concert series. On Tuesday, July 12th, Dr. Mary Maish, thoracic surgeon, presented Learn the Latest Treatment Options for Gastroesophageal Reflux Disease, also known as GERD. 40 people attended. Upcoming health promotions and community outreach events. On Saturday, July 16th, Washington Hospital and the Taylor McAdam Bell Neurosciences Institute will host the Advances in Neurosciences 8th Bay Area Symposium. Nationally and internationally recognized experts will discuss a wide range of topics focused on neurological diseases, disorders, and treatment approaches. The program coordinators are Dr. Sandeep Kunwar, neurosurgeon, Dr. David Larson, radiation oncologist, and Dr. Moses Tagioff, neurosurgeon. To register, call 510-791-3417. On Tuesday, July 19th from 6:30 to 8 p.m., as part of the Palliative Care Community Presentations, Dr. Vandana Sharma, oncologist, will moderate the Palliative Care Demystified panel discussion. The Palliative Care Community Presentations is a 3-part series designed to educate and demystify palliative care. Palliative care is about treating the physical, emotional, social, and spiritual needs of the patient and their family. On Thursday, July 21st, from 6 to 8 p.m., Dr. Sunil Dewan, dermatologist, will present The Sun, the Beauty, or the Beast. Also on Thursday, July 21st, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, will present Strong Women, Strong Bones. The presentation includes bone density screenings for osteoporosis. On Tuesday, August 2nd, from 6 to 8 p.m., as part of the Stroke Education series, Dr. Ash Jain, cardiologist, and Melissa Reyes, RN, will present Acute Management of Stroke and Chronic Care and Stroke Rehabilitation. On Wednesday, August 3rd, from 6:30 to 8 p.m., As part of the Washington Sports Medicine and Washington Outpatient Rehab Center bi-monthly education series, Dr. Stephen Zahner, family practice and sports medicine specialist, will present Big Changes in Concussion Care, What You Don't Know Can Hurt You. The Washington Hospital Healthcare Foundation Report. On Saturday, October 8th, the Washington Hospital Healthcare Foundation will host the 30th Annual Top Hat Dinner Dance. This year's gala will be chaired by Marlene Weibel, Dr. Albert Brooks, and Dr. Elizabeth Kirkjohn. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards a new prenatal diagnostic center, which will provide much-needed services to expecting mothers, especially those who are at high risk. The center will provide exceptional benefits to our community, including decreasing instances of low birth weight, improving pregnancy outcomes, and improving newborn and infant health. Additionally, it will enable many high-risk expecting mothers to deliver at Washington Hospital without having to travel outside the district for this specialized service. To receive seats at Top Hat or inquire about sponsorship opportunities, please call the Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. The Washington Township Healthcare District Board members attended the Newark Chamber of Commerce's Celebrating Business Luncheon on Monday, June 28th. Washington Hospital Employee Association, WIA. On Monday, June 20th, WIA hosted an American Red Cross blood drive. 35 employees registered and 32 pints of blood were collected. This is a record high for WIA blood drives. The next blood drive will be held on Friday, September 23rd at Washington West. On Friday, July 1st, WIA provided nursing services clothing items for indigent patients. At times, patients arrive in clothing that must be discarded after treatment, resulting with nothing to wear when discharged. Clothing items included t-shirts, sweatpants, undergarments, socks, and sandals. On Friday, July 8th, WIA donated 24 tickets to the staff members of Abode Services for the San Francisco Giants vs. Arizona Diamondbacks game on July 9th in appreciation of their work to support the community they serve. July 11th through the 18th, WIA will host a food drive to benefit those served at Abode Services. Abode provided a list of non-perishable items that are needed to restock pantries in various locations. July 18th through August 12th, WIA will have a backpack challenge for the Back to School drive. Each department is asked to donate items to fill a backpack for a student in need. The students range from kindergarten to college. Items collected will be donated by WIA to Abode and Save. Washington on Wheels WOW Mobile Health Clinic. During the month of June, the Washington on Wheels Mobile Health Clinic WOW continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, and the Ruggieri Senior Center in Union City. Washington on Wheels kicked off the summer's free glucose screenings at the Fremont Main Library, Centro de Servicios in Union City, and at all other scheduled sites. WOW provided 151 screenings in June, and of those, 22 people tested had higher than normal glucose levels. They are undergoing further testing and treatment for diabetes. Visit www.whhs.com/wow or call 510-608-3203 for more information on where screenings will take place. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of June was 186. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include Employment, Physician Finder, About WHHS, Volunteers, and Women's Health and Pregnancy. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the total number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of June, Washington Hospital's cable channel 78, InHealth, captured new programming, including a health and wellness program titled Pain When You Walk, It Might Be PVD, a sports medicine program called Think Running is a Pain? It Doesn't Have to Be, and a Diabetes Matters program titled Diabetes Roundtable Discussion. In addition, InHealth aired the Inside Washington Hospital Advanced Treatment of Aneurysms and the June Board of Directors meeting. Awards and recognitions. The American Shared Hospital Services, a leading provider of technology solutions for advanced radiosurgical and radiation therapy services, awarded the 2016 Lexel Gamma Knife Society Pioneer Award to Dr. David Larson, radiation oncologist. The Lexel Gamma Knife Society Pioneers in Radiosurgery Award is bestowed upon researchers who have consistently pioneered new approaches and methods that enhance the results of gamma knife surgery. According to AMS Chairman and Chief Executive Officer Dr. Ernest A. Bates, Dr. Larson is widely recognized for seminal contributions to radiosurgery. He also says that the award recognizes Dr. Larson's lifetime of accomplishments and his dramatic impact on the field of radiation oncology. Dr. Larson serves as co-medical director of the Taylor McAdam Bell Neuroscience Institute's Gamma Knife program and is the Professor Emeritus of Radiation Oncology at the University of California, San Francisco. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070, and please follow us on Facebook and Twitter.
Before I get to the Employee of the Month, I wanted to make a few remarks about our magnet survey. On the 27th, 28th, and 29th of June, we had a magnet survey team here of 3 nurses, all of them directors of nursing and administrators in their own professional lives. And as the survey went on and gained momentum, it became very clear that they were enjoying what they were seeing very much. When they saw the infusion center and also the simulation center, they began taking pictures. They asked permission first. They're taking them back to their own hospitals to show their administrators how it's done here. About 2 hours before the exit conference, one of the 3 surveyors came up to me in the lobby of the admitting department and threw her arms around me and gave me a big hug and said, "I just love this hospital," which made me feel like we were doing well. And when we got into our exit conference, all it was superlatives every inch of the way. And it was very clear that what they had seen was what you'd hope they see. That it isn't just the nurses of Washington Hospital that are magnet. It's all of the departments that support them. They went out of their way to compliment engineering and housekeeping and finance. I think they were deeply impressed with their interview with Chris Henry. And I believe, though I don't want to count my chickens before they're hatched, I believe that we'll be redesignated. I know that the nurses worked on this for months and months and months. And sometimes people wonder, what's the value of doing this? Right after we went through our first magnet designation, we also went forward with an aggressive schedule to implement our IT systems. And the concern always is that you're going to defeat the clinical agenda, imposing informatics on nurses that have not had to deal with them before. And contrary to my worst fears, we flew through that implementation. The nurses were not a source of trouble at all. If anything, they were helping everybody else. And when we got to the other end of that implementation, Stephanie and I were talking about, wow, this really went well. Why did it go well? And why it went well, I absolutely believe, is our nurses became magnet before this happened. And they have the evidence in front of them that, yes, they can do these things. And when everybody pulls together and works on a project together, they can achieve great things. And this togetherness does include all of the various departments of the hospital. So when we get the call that I hope we're going to get, telling us we've been redesignated, it will be a time for the entire institution to celebrate, because nurses didn't get there alone. They carried most of the water, but an awful lot of people helped them along the way. I think the magnet designation brings you staff that are self-assured, can think on their feet, are a greater assistance to physicians because they've learned how to think critically. And this is exactly what you want your nurses to be. So I'm looking forward to a happy resolution to our redesignation survey. I have every reason to be very proud of what they've accomplished already. Okay, with that, let's talk about our Employee of the Month. We have Rochelle Evans. She's been with us for 13 years. She's part of the Medical Imaging Services team. She's doing the IT end of things for our radiology department. She has DEXA certification. She is the technician and the informatics specialist who troubleshoots both the department's RIS and PACS applications. Cheryl Capisi, her manager, says Rochelle is like a daughter to the imaging team. We've seen her grow professionally while never letting go of her upbeat and positive energy. She is the type of employee who does what she's asked, or often does what we need done before she's asked to do it. The entire team appreciates and values Rochelle's contribution. That's quite a statement on the part of her manager. So I think without question, we can identify her as an outstanding employee who promotes the patient-first ethic on a daily basis. And she's deeply appreciative of the opportunities that have been provided to her through her employment at Washington Hospital. She is a resident of San Leandro. She enjoys spending free time with family and friends, which include her nieces and nephews, who she adores. She's also a traveling fanatic, and she's traveled all over the United States. And later this year, she's going to travel internationally, and will be visiting Thailand for the first time. She's also a big Warriors fan and was a very lucky young lady because she, in addition to attending home games, she was able to get away to games out of state. So I think she'll be very excited later this year when we find out how the Warriors are going to do with their new Big Three.
Well, thank you, Nancy. Any questions? Thank you. Okay, we're going to move on to the Lean Kaizen update.
It is my pleasure to introduce two individuals tonight, Brenda Brennan and Dr. Coy Lamb, who have been integral in the Lean journey in the emergency department. They, along with many other individuals, have taken on initiatives and have really improved the patient experience and the experience for physicians and staff in the emergency room. So to begin with, Brenda Brennan has received her nursing diploma from Little Company of Mary Hospital in Chicago, her BSN from Chicago State University, and her master's degree in nursing from UCSF. Brenda started her career at Washington Hospital in August 1987 as a registered nurse in the emergency department. In February of 1989, she assumed the role of clinical nurse specialist for the emergency department. In 2014, Brenda was promoted to the position of Emergency Services Administrator. In this role, she has the responsibility and accountability for the overall strategic and operational planning and provision of patient care for the emergency department, emergency observation unit, and future trauma services. Brenda has been with Washington for 29 years and has been very active in many institutional initiatives, including but not limited to disaster preparedness and lean implementation. Brenda lives with her husband of 32 years and is enjoying being an empty nester. Next is Dr. Corey Lamb. He's the emergency room physician who has been on the medical staff at Washington Hospital since 1999. Dr. Lamb did his undergraduate work at UCLA, attended medical school at UC Berkeley, and completed his residency training at King Drew Medical Center in Los Angeles. Dr. Lamb has participated in a number of Kaizen workshops for the emergency department and is helping to champion improvements for the ED physicians. Dr. Lamb lives in Fremont with his wife and 2 children. Thank you.
Okay, I'll make mine lower. Good evening. Thank you for this opportunity to share the emergency department lean journey with you tonight. We're pretty proud of our accomplishments and are happy to be here. With recent changes in the healthcare environment, the emergency departments across the United States have seen significant increases in patient volumes. Our emergency department in particular has seen a 20% increase in the last 10 years in patient volumes. We were told that when we hit 50,000 that we would be officially a big emergency department with big problems. And with that increase in volume, we saw that our processes were causing delays in patient care, that we had increased wait times, and didn't have patient satisfaction where we wanted it to be. And so we were very happy to be chosen as the second value stream so that we could work on improving our processes.
Just want to correct Kim real quick. I went to undergrad at UC Berkeley and medical school at UCLA, just minor stuff. No big deal. So what is the lean vision? Well, first and foremost, it is a commitment. It's a commitment from the Washington Hospital, and especially in the ED department, for patient-first ethic, to improve patient experience and quality of care. And how do we achieve this lean vision? Well, it is to understand the processes that occur in the ED. Do it systematically, logically, and rationally, and to create what we call a value stream map. And as you can see on the slide, there is consistent of several steps that the patient experienced from the first step they walk into the emergency room to the time disposition is made from the emergency room. And from these steps, we identify, analyze the waste, the waiting time, and by employing the lean tools, we're able to achieve or to improve the process and eliminate the waste. And by improving this map stream, and we hope by learning the mistakes and the improvement, we hope to redesign the future state for an improved patient care and patient experience.
So this doesn't happen in one workshop. It takes a series of workshops where you're unscrewing the pickle jar top as you go, and you get a little bit more off each time. So far, we've had 6 workshops for the emergency department. The value stream map that Dr. Lamb talked about, we 5S'd, we cleaned up the department. We did an arrival, registration, and triage workshop. We had Care Coordination 1 and Care Coordination 2. Then we worked on a combined workshop with inpatient admitting and the emergency department. And finally, we worked on the financial registration process. What I found really noteworthy and unique about these workshops was that it was no longer the emergency department alone trying to solve its problems. It was inside eyes and outside eyes. And it was that collaboration of all the disciplines working together with no titles and thinking about what could we do different to improve our processes that really makes a difference.
So our first workshop in June was value stream mapping. It is a map, like I stated previously, consists of several steps from patient experience from the onset to the time of disposition. It used to analyze the current state of work in the ED and to help to design the better and future state. And some of the improvement plan that we learned from this value stream mapping is to optimize it, to improve the time of arrival to the time of registration triage, and also to help to improve the standardization of registration for patients. And thirdly is to monitor patient physician practice and patient flow from the time the patient was roomed to the time the physician was able to see the patient and to start the initial workup and treatment. And also we used to the map to create the standard work for the nurses. So it can be repeated, can be relied on, and to help to improve the patient care. And ultimately, all these steps are designed to improve patient experiences in the ED, to help to communicate better with the patients, to improve the privacy and the comfort for the patients. And at the end of the day, in order to achieve all this good, we were able to work with other departments, radiology, labs, to improve the turnaround time for these results, and also to ensure the efficiency and the improved care for discharge or admission for the patients.
So in our second workshop, we did what they call 5S. So we sorted, we set in order, we shined everything up, cleaned it, standardized things, and sustain it. So the goal is to have the right equipment in the right place at the right time so that we eliminate the waste of looking around the department and searching. So we neatly labeled our supplies. Stephanie was incredibly active in the labeling of supplies. She was side by side with the staff in the department, cleaning and labeling. We created bedside carts to eliminate steps for the nurses in terms of leaving the bedside to get supplies. We removed unneeded or broken equipment. Sometimes we removed something that had to be brought back into the department. And we really focused on the treatment areas, our workstations, the fast track area, and reduced supplies in our Pyxis and in the cast room. And as an outcome, one of the things that we were measuring was how many steps did it take for a nurse to get supplies in a shift. And we reduced it by 52%. We went from 6,000 steps a shift to 2,890 steps a shift.
And the third workshop is the focus on the arrival experience for the patient and the registration on the triage building and the triage itself. And the goal is to decrease the time the patient spent out in the triage building, and also an opportunity for us to improve patient care ultimately. How to improve it? Well, one of the area that we work on is to ask the registration clerk to act as a greeter and also initiate the registration on patient's arrival, and also use multiple signage to direct the patient and their family to where to go and where to wait, and also minimize the paperwork, the red tape, if you will, for the patient to sign in and to initiate the triage process so we can take the patient back to the emergency room faster and quicker. And also to standardize the work for the triage staff as well. Again, that would help improve the accuracy and the reliability of the data once the patient arrived back in the ED. And a positive outcome, so that since the 9 months after we implemented these changes, there was an increase in patient satisfaction with arrival and financial registration, and better than target. The increased satisfaction with arrival was from 75 up to 81.8%. The target was 78%, so it's more than 3% expected. And increase in satisfaction with registration from 83 to 86, better than 85 expected.
So as you can see, our workshops follow the process that a patient follows in terms of their arrival into the emergency department. So the next logical step was, how do we look at the time from their room till the doctor does a medical screening exam, until orders are placed. And so our goal was to improve the efficiency of having that medical screening exam happen and improve communication, assisting the physician. So we created a Flowmeister role. So the charge nurse is now known as the Flowmeister, and they poke at the ER doctor every 10 minutes. There's a patient waiting to be seen, and it's actually been really very effective. Within the last 7 months, we've decreased the time from the time the medical screening exam took place until the time they placed orders from 12 minutes to 6 minutes. And we did a lot of work with technology, working with John Lee and his team in terms of making sure that Epic was up and operational in the rooms, reducing the amount of time that it took for them to log in and have confidence that they could place orders at the bedside.
The fifth workshop is to continue on the success of the previous one. It's called a room to disposition, which is the goal is to decrease the time when the patient was roomed to the time the patient was disposed from the emergency room, whether discharge or admission. And the plan is to work on reduce the delay and the turnaround time of the test results. And we work with the laboratories and also the radiology department with the help of Epic to create order sets and programs to facilitate. A good example is in the past, the CAT scan tech would have to go to the ED, check in the patient to see whether the patient is ready to get a CAT scan or not. By using Epic and work with radiology department, we were to design a software program, if you will, where once the patient is ready from the emergency room department, the green light would show up in the radiology department to notify the technician that the patient is ready to go, and therefore decrease the waste time of the radiology tech have to come back and forth to pick up the patient. And again, we also have the flow nurse, the charge nurse, to keep track of this task, of the time, of the patient's waiting time. And we also create a standard work, thanks to Epic team and information department, to create standard work in Epic for radiology lab and also ED physician and ED department as well. And one of the things we created to improve the efficiency is to use the ISTAT result in the emergency room to get the renal function test, turn around faster, and get the patient over to CAT scan much faster. I believe we cut down the time of order to get a CT scan down to decrease the time by 60 minutes.
Close to 60.
Close to 60 minutes. So the outcome from all of these improvements, the last 6 months show that the patient was discharged twice as fast as they were pre-workshop. The lead time is the total time that the patient spent in the ED before discharge was from 5.3 to 2.6 hours. That's almost 50%.
Are you tired yet? Our sixth workshop was one of our most challenging. We were the first opportunity to have a double workshop go on at the same time. So we are not an island. The ER can't admit patients if beds aren't available for patients to be admitted to. And so we worked with 4 West in the emergency department. We had 2 significant groups divided into many sub-teams looking at how can we improve the discharge process on 4 West so that we can get patients admitted from the emergency department. So we developed a signal system in the emergency department. Sometimes the nurses didn't know that they had a bed available, so we improved that for them. We found out that nurses were reading report to each other. And so we worked with 4 West to develop a tool in Epic that they could go to and find the information that was most important to them. And we had an agreement that within 30 minutes the patient would come upstairs automatically, with some caveats that we would call significant information or they would call with questions. At the same time, we call for an appointment with transport, and we say, it's 7:25, this patient needs to leave by 7:55, and transport comes and takes our patients up to 4 West. 4 West had many of their own initiatives in terms of the discharge process, one of which was a discharge checklist that they implemented so that they were getting everything ready for the patient to leave. One of the metrics that we look at in terms of trying to pull apart where can we make an improvement is the time from the admit order placed by the ER physician to the time the supervisor assigns a bed. We had metrics that were up to 120 minutes sometimes. we're down to 106 minutes, and now we are at 31 minutes consistently from the time we have an order until we have a bed assigned for the patient to go upstairs.
Okay, last but not least, financial registration process. So again, we want to improve the efficiency of the financial registration process for the patient. In the past, it's been we have several places where the patient can be registered, several locations, and it was confusing. It was time-consuming. And the paperwork sometimes get lost in the process during the registration or before discharge. So we have a workshop where we design their single checkout location for the patients and the family for registration. We also have designated area to complete the registration. And we also have a volunteer to assist the registration clerk out in triage to greet the patient, the family, and also to assist with the registration process, and also to help to bring the family and the patient back into the emergency room. It was done recently, so the initial outcome was positive. It helped to decrease the process about 12% from 75 minutes to 66 minutes.
So as you can see, we've made a lot of gains in the emergency department in the past year. We're very aware that our success is dependent and attributed to the collaborative efforts of all the groups at Washington Hospital. The experience for patients is improving in the emergency department. We have teamwork and collaboration that's improved in the past year. We have standardized tools and processes. And the staff and physicians are more than empowered in terms of coming forward with suggestions of what additional things we can do to make things better.
So what are the next steps? So with these positive results, our hope is that we will incorporate these lean cultures into our daily working lives for the staff and for the patients, and also to help to initiate to develop strategy for the future and problem-solving methods. But the key for this, again, is patient, and patient. It's patient-centered, patient-focused, and we try to look from a different perspective, a paradigm shift as to what are the expectations from the patient and what would the patient like from the staff. And it is a continual process. It is continually process, reevaluating, improve on previous positive experience, and also continue reevaluate to eliminate waste. And for the near future, we are all very excited. Hopefully this experience to help us prepare for the next great transition into the Hyman Critical Pavilion. And next workshop, we're not quite done with that, is going to be on September, and that's going to be to improve efficiency in fast track.
Dr. Lamb was right, we're never done. It's continuous improvement. So the ER is not an island. If we could have done this before, we would have done it already. And so it really required the opportunity to participate in Lean, to be early adopters, and we're most especially grateful to Nancy and Stephanie for allowing us to be part of that early value stream so that we could make these improvements in the emergency department. Thank you.
Brenda, can I ask you, what has been your length of time that you've been exposed to the Lean principles? When did you first?
I first started my training, I guess, 2 years ago. So I became certified as a result of working in all these workshops.
Yeah. Well, you have amazing accomplishments. Both of you should be congratulated in the entire department. It's just amazing improvement in the
Thank you.
numbers.
Thank you, and the work's not done.
Yeah, I know that. The reward for good work is more work, right?
Yeah.
Okay, we're going to move on to the construction report. I saw Ed wandering around.
Ed is here.
He's still crowing about Cleveland. Then I had to hear about. Then I had to hear about the Cleveland Clinic. I think Ed was behind that too.
Cleveland, and more Cleveland.
Yeah.
Okay, so I'll give the construction report. First, the garage. Actually, we finally have some good news on the garage, and that is that we got our temporary occupancy permit last week. And we are wrapping up the odds and ends to the job. So right now we have a scheduled date to open it up for business on August 1st, and the main things that we have to work on now are basically control of traffic, getting back to the garage, and some work on some of the flow of the traffic in and around the garage. The only things left really in terms of construction is we have a fence in the very back that's still supposed to be done by the 25th of July. And then we still have the fence that's going up within the garage itself. That's all supposed to be done by the end of July. So the BART building core and shell is also going along well. So we should be totally out of this construction by the middle of August in terms of everything being wrapped up. But again, opening in the 1st is the plan. So here you can see they're just cleaning up basically after all construction activities done. This gives you an idea of what's happening in the BART building, and that's coming along. This is bioretention, bioswale in the back. If you look, this is the last section of fence that has to be completed between BART and the hospital, and that's really the last quote-unquote construction part of the job. It's not done. Here you can see curb, gutter, sidewalk going along. This will also open without being totally planted, but there are trees and a few other things. Ultimately, we'll probably have some lights in there as well, though it's lit at night now from the building. We will have lights as well on the sidewalk after we open up. So very close at this point. And I thought you might want to see this. We had some shots from a helicopter that came by. You can see the helipad landing site on the garage. This is supposed to be open right now, planned for August 15th. We'll have a few dry runs and test it out in terms of our policies and procedures and things like that. So getting close all the way around for the functioning of the garage. Any questions? On the Hyman Pavilion, that is still going along extremely well. Just as a side note, I was invited out yesterday. They had a huge barbecue. We must have had 250 workers there as a recognition for what's been done in safety, and that we started in March, so we are now, 15 months into the job, and the totality of workers' comp that has been paid out is about $2,000, and there's only a reserve of $40,000 for anything that's happened so far. Safety record is outstanding, and a lot of credit to Rudolph and Sletton. And then also, Aon is our third-party administrator, and they have been actively involved. But Rudolph and Sletton has really done an outstanding job in the safety on this job. So here you can see the ground floor starting to get closed in. This is actually one of the data room down there. Here you can see scaffolding going on. If you look out there now, they're putting up the scaffolding to start the work on the exterior of the building. So they have the exterior or the scaffolding going up outside of the moat. And first floor, as you can see here, sprinklers and studs, things like that. The ties for mechanical. The fourth floor has been poured out totally, so all the concrete on all the floors now is completed. This gives you a little shot of the atrium that goes up the four stories. You get a little sense of that, and so here's where we're at. Things are going well. As Pat likes to hear, on time, on budget, and really no problems to report. Okay.
So we're shooting by the end of the year to have the building watertight in case it
Yeah.
rains, in case it rains again over in California.
They officially, if you look on the schedule, they officially have it quote-unquote watertight in July of next year. But the exterior skin should be on. Their scheduled time is January. It's not totally closed in because I still have to get a lift and things to get in. So there'll be a section that's still open through the winter, and then it'll be closed up after all the material and such has been moved in. So practically speaking, by January, we should have the skin completed, and it be, they're planning to have all the interior painting done by March. So, I mean, it's effectively watertight, but they don't consider it that way until next July.
Okay.
Oh, so the base isolators are now active, and they pulled the guards off last week. And so that effectively now is sitting there, and if we do have an earthquake, we have that protection in there. So that's a good news.
Wow.
Ed, could you give us all notice on that when we're getting an earthquake so we can get in that building?
Well, there's some things I can do, but that's a tricky one. Okay.
Thank you. Yeah, you just have to jump up in the air, you'll be all right.
There we go.
Okay. All right, we're going to move on to the quality report then.
Good evening. Tonight, I would like to talk to you a little bit about what we're working towards with regard to optimizing quality and our patient experience in our neonatal care unit. Some background on how we developed our special care nursery, otherwise known as the SCN. In 2014, we partnered with UCSF to open up a level 2 special care nursery. And that actually made us the only intermediate infant intensive care unit in the Tri-City area. So we focused on establishing 2 goals after opening up this new service line, and one of which was to really provide the patients of Washington Hospital community with a place that's local to their own area where they live, so that if they do have a patient or a baby that has a high-risk situation, we can keep them in the community and they can receive their care locally. While doing that, we also wanted to provide specialized and nurturing care at the highest quality for these infants that are born with special needs. So the type of patients that receive the care in this unit are recovering newborns, premature babies, and babies that require a specialized care and hospitalization. For these babies that require even a higher level that goes beyond the SCN, we work towards stabilizing them and making sure that they can be transferred out appropriately to UCSF. Our program structure is made up of 11 licensed beds. We continue to build on our affiliation with UCSF to make sure that we have specialists that are available in helping us provide the appropriate medical treatment to these patients. This team is made up of an interdisciplinary group that partners with a neonatal team. And all of our nurses that at work in the SCN have a specialized training known as Neonatal Resuscitation Program, which is an NRP equivalency. Our leadership care team is made up of a medical director. He's affiliated with UCSF. And we also have a senior director working in maternal health with an extensive background in providing this type of management to these type of employees. And she's also supported with a nurse manager. So really what we want to do is continue to keep these patients aligned with our patient-first ethic. So we have to make sure that all the care there is focused and patient-centered. We do that by making sure that we partner with the families to provide the optimal care at this local level while they're staying here at Washington Hospital. This care is obviously provided around the clock, where we focus on the patient's nutrition needs, the growth and development need of that baby. We also encourage a lot of early bonding between the parents and the baby, and try to support the family into making sure that they still have lactation services provided so that we can, give them the opportunity to breastfeed if that's an option for them at the time. We have a dedicated lounge area for the parents and families to stay, and we just work towards making sure that they have a lot of support even when they are discharged here, so they can prepare for these patients at home. We've been working on some quality improvement initiatives for, I wanted to go over a couple from calendar year 2015, one of which is providing a non-invasive respiratory treatment for these babies called continuous positive airway pressure, otherwise known as CPAP. That's really helps patients of this type that are having a hard time breathing, but it gives them a non-invasive support to help them breathe without actually fully intubating them if they don't need it. We also have made sure to get these patients, the babies, close to their parents with having skin-to-skin contact whenever possible for any infant that's eligible for this. Communication, as you know, is one of the backbones to quality, and it's one of the best ways to improve quality outcomes. So we focused on an initiative called Team Steps in the Birthing Center. This really encourages and teaches the team how to improve their communication amongst one another. Also work towards improving the way that we collect our blood cord gas results and making sure that those are done appropriately and timely, and always providing the patients with the education and the explanations of this care, because majority of people have never been through something like this. It's a very traumatic time for them. They don't know or recognize a lot of the things that we would be doing, so it's constantly familiarizing them with the environment and the interventions that we're doing and why we're doing them. One of the best measures of our improved respiratory support is by looking at the device that I just mentioned earlier, the CPAP, otherwise known as the less invasive bubble CPAP. You can see here that for patients that were able to use the CPAP, they actually only had to be on it for about 14 hours versus a patient that had to be on the ventilator CPAP for 23 hours. So anytime you can get them, like I said, on a less invasive respiratory device that supports the breathing, you decrease the chances of them developing a pneumonia and other complications. Another big focus for the SCN has been on the patient experience. And while as I mentioned before, we've been really looking at this as a new measure that we're looking at. So the data is only about a little less than a year. So what we're starting to look at is, are we making sure that patients are satisfied with the attention that we're giving the special needs to their infant? And are we giving these instructions clearly? We take their feedback very seriously to make sure that they're understanding what we're giving them as far as the education and instruction goes. And making sure that the SCN nurses themselves specifically are working close with the family for this instruction. So those are the things that we'll be looking at, especially over the next year, to make sure that the patients are having a good experience with that, and we'll continue to monitor the outcomes for that data. While Magnet was here, they met with community members, and I had the opportunity of going and listening to the stories from the community about their patient experiences here at the hospital. And while we went there, I was able to meet with a patient that she had twins here at the hospital, and she spoke very specifically about her experience with SCN. We wanted to share that with you this evening. To give you some background on what her situation was, she had a history of an ectopic pregnancy. She went into also preterm labor, ended up delivering twins. Here they were born in May 2nd of 2015. Her babies were obviously low birth weight babies being developed prematurely. In fact, baby A only weighed 3 pounds 7 ounces, and baby B was 3 pounds 9 ounces. So they were dealing with the typical issues of cardiac dysrhythmias, respiratory problems, and we were able to keep them here while we could. At one stage during their admission, one of the babies did have to be transferred out to another facility, but there's a protocol that we like to follow strictly in not separating twins. So her sibling was able to go with her, and both the babies were transferred out. After the babies were stabilized at the other facility, this mother felt very strongly about trying to get her kids back to our area so that she could be close by and be able to maintain all the things that she's trying to maintain at home, such as, the household, supporting her own family, but being able to be close to her babies, which again is one of the goals in developing an SCN in our area. So those patients, the babies did come back, and we were able to provide weekly conferences with them where they met with everybody, social services, the doctors, nursing. There's a lot of good communication and support provided for this family. The outcome of this is that baby B was discharged first. They were stable enough, and the nurses were able to provide a lot of support throughout this process. A lot of education, again, is required, especially for involved in the discharge planning. Baby A required some higher level of care and did stay dealing with some GI issues. But during this whole process, the mother was very involved in being able to stay at Washington Hospital and work closely with the medical staff and the nursing staff. And one of the things that I was discussing with her is, she said, this was probably one of the worst experiences for us to go through, for my husband and I, to be faced with this. And I wanted to share a couple of the quotes that she felt about our hospital in spite of, dealing with this stressful situation she was going through. And she told me, I wouldn't have chosen any other hospital for the birth of my babies. In one of the most challenging times in my life, the staff treated me and my family well, and I felt safe leaving my babies here. She said every day when I went home, when I had to go home and spend the night, I felt very rest assured that my babies were safe. She's been a Fremont local her entire life. Her family has relied on the staff and been coming back and forth for all their medical needs at Washington Hospital. And she said, this is by far the best experience we've had considering the circumstances. So we figured that was a good outcome of our new service line in SCN. Any questions?
Thank you, Mary.
Thanks.
Any questions? Thank you very much. That is good. Okay. Chris, hi.
All right, thanks. Tonight we'll be looking at the results of operations and the financials for Washington Hospital for May 2016. Average daily census for the month was 151.3. We'd expected 157.4. Admissions were 5 above the budget at 1,029, but our patient days were 187 below the budget at 4,691. That's not necessarily a bad thing. It means that we're being, it's an indicator that we're being more efficient in getting folks out. Outpatient observation equivalent days for the month came in 26 below budget at 246. Our average length of stay for the month, as you might expect from the numbers, lower than budget at 4.47. Looking at utilization, case mix index for the month was also lower than we expected the month at 1.479, so that may be part of our shorter length of stay. We had deliveries that were 13 above budget, 177. We had 44 more surgical cases than we expected in the budget at 411. That includes our joint replacement cases that were 21 above the budget at 137. Our neurosurgical cases were just 2 below the budget at 24. And our cardiac surgical cases for the month were 2 above the budget at 12. Cath lab procedures for the month were 69 below budget at 352. Outpatient visits in the month came in 204 below budget at 7,212. Of note, about 145 of those represented visits that we had expected from the prenatal diagnostic clinic that we haven't quite gotten open yet. Emergency room for the month was historically pretty busy at 4,554, but 129 below what we expected in the budget. Quick look at cath lab activity. Peripheral vascular continues to dominate the activity in the cath lab, followed by cardiac and our interventional radiology products. Quick look at productivity. Productive FTEs for the month came in 36.9 above the budget at 1,255.8. Our non-productive FTEs were 31.2 below the budget at 156, giving us total FTEs 5.7 above the budget at 1,412. Our FTEs per adjusted occupied bed for the month, just a little bit above budget at 6.82. Moving into financials, first we'll look at our Governmental Accounting Standards Board presentation. For those not familiar with this is the presentation we're required to use for our audited financials. Total patient revenue for May came in about 1.4% below the budget at $169,862,000. Contractuals for the month a little bit higher than the budget at 77.39%. We did have some higher governmental sponsored patients. We've had some swings in this from month to month. Year to date, if you take a look at that, we're pretty darn close to what we had expected for the year. So we ended up May with net operating revenue about 3.8% below the budget at $38,617,000. Operating expenses for the month came in about $600,000 below the budget. Variance driven in the areas of our health and welfare costs were below budget. Also, our purchase services and pro fees really drove a large part of that. We saw that in the areas of lower medical fees, legal, consulting. Really we're controlling those in the month. Those variances were offset by a little bit higher than expected provision for bad debt. We did have a higher percentage of private pay patients in the month. So we ended May with an operating bottom line of $1,357,000, about $914,000 below what we expected in the budget. Non-operating income for the month came in about $366,000 below what we expected in the budget. That was driven by an unrealized loss on our investments as those things continue to bounce around. So we ended up May with a total bottom line from a GASB perspective of $2.7 million, about $1.3 million below budget of $3,989,000. Take a quick run through our Financial Accounting Standards Board presentation. This is the way financial markets might adjust our numbers to look at us. Operating bottom line stays the same at $1,357,000. We pull out our tax revenue that supports the debt service on our general obligation bonds, and that unrealized loss in our investments from our non-operating income to end up with non-operating income pretty close to budget from a FASB perspective at $356,000 and a total bottom line of $1,713,000. So are there any questions on May's results?
Questions?
Okay.
Thank you.
Ready to go?
Yep.
All right, let's get my slides on. Okay, this is the preliminary operational report for the month of June. Our gross revenue for June came in about $9 million below budget, a 5.3% negative variance. But it is higher than that of June a year ago. The inpatient gross revenue was $6 million below budget. The outpatient revenue was about $3 million below budget. The major drivers of unfavorable revenue variances are the census was 8.6% below budget. Our room and board charges came in $2 million lower than we had expected. The lower census drove ancillary service revenue below budget by 5.8%, or $4.3 million. The inpatient ancillary revenue was down by $3.8 million. The outpatient was below budget by $500,000. The cath lab procedure volume was 19% below budget, driving the cath lab revenue lower than expected by $1.6 million. And we've looked at where this has originated from, and there are three physicians in particular, one of whom has been away from the hospital a lot because his father is suffering from a terminal illness, and by far and away his drop in activity is the greatest. Our emergency room volume was 7.7% below budget. The idea that they would have less visits, on the one hand, you'd like to see them get a break, but on the other, doesn't help the hospital. Let's see. We'll go to the key statistics, the key census slide. Our admissions were 956 below budget. Our average length of stay was 4.39. That was also lower than expected, and it drove the patient days below budget. Our emergency department visits were below budget by 337. Admissions. They continue to trend pretty close to budget and are within about 2% for the year. Patient days are also trending close to budget and are about 2%, within 2% of the budget. Cath lab trend. The procedures for June were 332 in number, but that was 78 cases below what we had budgeted, and that's the 19% variance I've been talking about earlier. Cath lab activity, peripheral vascular procedures were under budget by 47. That's a 26.3% negative variance. Non-vascular IR procedures were below budget by 23. Cardiac procedures were below budget by 8. Our PTCAs, though, were above budget, which was extremely helpful. But this speaks to the point I was making earlier that one physician in particular, who has been away a great deal of time, constitutes the greatest source of variance. Neuro IR procedures were on budget at 14. In terms of surgical trends, our cases in June numbered 380. They were below budget by 11 cases. And our surgical cases are going to come in higher for the year, even though they've been lower in the last 2 months. They're going to come in 403 cases higher than budget for the whole year. So the operating room has done very well. Surgical activity, the main variances come from general surgeries that were below budget by 13 cases, neurosurgical cases that were below budget by 3, and those unfavorable variances were offset by the joint replacement cases that came in above budget by 3, and cardiac surgeries that were above budget by 2. In terms of deliveries, we had 151. They were below budget by 7. They were, we're looking at a negative variance of 2% for the year, 31 cases. And considerable amount of this is related to the opening of the prenatal diagnostic clinic, which has been delayed because of the recruitment issues at UCSF. June's deliveries came in 10 higher than June last year. Non-emergent outpatient visits of 7,173 were reported, and they came in under budget by 698. Lab visits were below budget by 14.6%. The prenatal diagnostic clinic also had been budgeted for 155 visits, but it, once again, hasn't opened. In terms of productivity, our productive FTEs were below budget by 60.1 at 1,169.3. The non-productive FTEs came in above budget by 38.3. Total FTEs of 1,380 were below budget by 21.8. Our productive FTEs per adjusted occupied bed of 6.31 was 4.6% above the budget. Taken into account needs to be the fact that we were preparing for a magnet survey and that we were carrying considerably more staff as we went through that survey process and the ramp up as well. Now, let's see, other operational statistics. The surgery center had 500 cases in June. That was only 7 cases below budget. Clinic visits for the month of 3,582 were 303 visits lower than the budget. Payer mix. The overall payer mix for June was favorable to budget. Government-sponsored patients made it up 69.6% of total gross revenue, compared to what we had budgeted at 71.6%. The PPO revenue was 23.2% of gross revenue, which was above budget of 22.5%. Private pay revenue was 2.8% of gross revenue compared to the budget of 1.8. And I think what you're seeing there are people taking the option of paying the fine and not buying insurance. Key financial statistics. Days cash on hand. I want you to look at that number and enjoy it, because in California, hospitals participating in the Medicare program have an average of 33 days. And that kind of puts that one in perspective. The days in accounts receivable were 60. There were $355,186 of charity care applications pending or approved in June. And I would imagine we'll see that figure go up as we go through the year, as more people show up on our doorstep without insurance.
All right, Nancy, well, thank you very much. And I assume we're going to have a closed session?
Yes, we need a closed session.
Okay, we are now going to adjourn to a closed session. Thank you all. We'll see you shortly, hopefully. We are going to reconvene the open session and announce that there were no actions taken in the closed session, and consequently, this meeting is adjourned.